Okay, so it's 3 o'clock. Good afternoon and good evening, everyone. Welcome to today's session of Jaipur Surgical School. For those of you who are joining or who would be watching for the first time, Jaipur Surgical School actually is an extension of Jaipur Surgical Tutorial, where we have a class every Saturday, 9 to 10 a.m. India time, which has been going on for last 3 years. It has been looked after by my colleague, Dr. Anand Nagar. But many colleagues from Africa especially requested change of time because they could not attend the morning session. So instead of changing the time, we've started another session on Friday afternoon. I must say that these sessions, the live attendance is small, but as we have been observing, most of the videos that the Ahmedabad group of Dr. Avinash Tak, so the videos which we post of these recorded sessions, they are watched by a good number of students and surgeons. So I think our effort is not going down the drain. Some students, some surgeons are watching it, and I'm sure they are benefiting from it. So today we have a very eminent speaker, Dr. Puneet Dhar. He used to work earlier at Amrita Institute in Kochi, down south in India, and then he moved to All India Institute of Medical Sciences in Rishikesh, and now he has come back to the Amrita group, but in Faridabad, near Delhi, in the National Capital Region. He is one of the senior GI and HPB surgeons of the country, a very good speaker and very experienced surgeon. So he has kindly agreed to tell us about approach to cystic tumors of the pancreas. I mean, we all hear about the common pancreatic ductal adenocarcinoma and periampullary cancers, but with imaging, we are now seeing more and more of these tumors. So it's very important to know also because these tumors are eminently treatable. Their outcome is much, much better than the usual adenocarcinoma of the pancreas. So it's very important that we don't miss treating one of the cystic tumors because these patients, as I said, are eminently curable. So over to you, Dr. Puneet.
Thank you so much, sir, for a kind introduction. It's a privilege and honor to be a part of this. This is my inaugural session at the Jaipur Surgical School itself. So greetings to all the people in India, our Pan-African friends, as well as SAARC countries. This is an important clinical conundrum which can come up suddenly, and it doesn't follow a very traditional pattern. And sometimes the treatment patterns seem to be changing over time as we recognize them more and more. So greetings from Amrita, Faridabad, and that's the typical patient we will get where you on imaging, as Professor Kapoor said, you can get a incidental or actually on some investigation of a symptom you get this kind of a treatment. So it could be a variety of these kind of tumors, or indeed it could be just a pseudocyst. So when we are faced with a problem, we don't know what, it doesn't come with the label. So there's no point in theoretically, covering only as the pathology. We need to see clinically how they present to us. So typically you will get in your outpatient a lady like this, 44-year-old female with epigastric pain radiating to the back early on, diagnosed as acute pancreatitis. At that time, there was a rise in serum amylase. This settled in 1 week. So the patient is now not it's pain-free, but gets recurrent pain after 2 weeks. And the CT abdomen is done now, which shows a fluid collection in the distal pancreas. So now the worry is it a pseudocyst? Because although it's within 2 weeks, we don't call it a pseudocyst, but is it a non-tumorous cyst, inflammatory cyst? So advised observation and treat with pancreatic enzymes, which is what most of us would do. Sometime later, gets still no pain, no symptom, but a follow-up was advised. So they find a thick-walled cystic lesion. Now, when they persist, we are a little worried. And when they're already thick-walled early on, there is a worry. But now EUS and FNA is done. Cytology shows non-malignant cells. Fluid amylase is high. So patient patient is referred to you, and what do we do? So that's basically the kind of patient we need to discuss what to do. So they do a EUS FNA. So one of the common ways for looking at it is the endosonography. You locate the cyst, look at its features there. You can do a needle aspiration if it is needed. Now, do we need this in all cases? That's what we're going to see now. Are they malignant cells or not? Is the amylase high? Does that always mean it is benign? So fluid CEA was done, which is awaited. And while we await, we'll just run through the potential problems, some of the pathology, and what we expect. So as Professor Kapoor said, very frequently 20% of incidental imaging can show cysts in the pancreas. Likewise, in autopsy is an equal number. We see cystic lesions, and as age increases, we see more of them. So some of them are definitely increasing with age. The numbers increase with age. Most of them tend to be asymptomatic and are pseudocysts rather than true cysts. And very few of all the cystic neoplasms actually have a malignant potential, which is what we are really worried about. But a larger subset than this 10 to 15% may need to be actually, dealt with the suspicion that they could be malignant or potentially malignant. So the differential diagnosis of a cystic lesion includes pseudocysts, which can be after inflammation, after acute pancreatitis, or after trauma. The trauma can disrupt either the pancreatic parenchyma or the duct, and some of the pancreatic ferments can leak out, and this liquid can collect as a pseudocyst. Tumors itself can have cystic degeneration, but they don't have a lining. So basically, if you remember our general surgery, a cyst is a fluid-filled cavity which is lined by epithelium or endothelium. So everything else is if it's not lined by epithelium or endothelium, it is not a cyst. So technically, it's a pseudocyst. In the pancreas, pseudocyst term itself implies mostly, colloquially, it is used for the post-pancreatic or the post-pancreatic or the post-traumatic setting. So likewise in tuberculosis, if you get a caseating necrosis or a sort of an abscess, a cold abscess, or there are hematomas which are resolving, they all are pseudocysts. You can have non-neoplastic true cysts. So like we get cysts in the liver, kidney, it's actually a part of the same syndrome. The adult polycystic kidney disease can rarely have cysts in the pancreas and lungs as well. So true unicystic congenital cysts are rare but possible. So we do need to look at them. So, and if they are seeing them on serial follow-up as the same and they're there early on in adulthood, it's likely to be a non-neoplastic cyst. Likewise, cystic fibrosis, mucoviscerosis also can have cysts, as can duplication cysts. These are all genetic. Retention cyst can be there in chronic pancreatitis, which is also actually because it still has a lining. It is a true cyst, but it's not neoplastic. Probably doesn't carry a real malignant potential. Probably doesn't need treatment, except if it is associated with chronic pancreatitis symptoms. It might need treatment on its own merit. And finally, we have the other type of cyst, which in other areas is important. Pancreas, it's not that common. The parasitic cyst, of which hydatid is the most common. The only applied thing, for pancreatic hydatids is that this is the only place where we do not use colicidal agents if we are dealing with hydatids. So we tend to either simply drain them or resect that area, because the risk of pancreatitis without that is very high, or even with colicidals is very high. And finally, we have the topic of today's discussion, the cystic neoplasms. So we need to put it into perspective. So that's why I thought we should get an idea that what all it can be. So inflammatory fluid collection. So basically, if there's a history of acute pancreatitis, this is quite likely. But the reason I put it in today's session, we're going to have separate sessions on pancreatitis. But it's important to remember that pancreatic cystic neoplasms can also cause pancreatitis or can be associated with them. So that's a very important thing, that merely if there's a history, do not discount it. You must have at least an awareness, and that's why that the person in the first case that I mentioned was able to send it, and they might find that the CA is high or whatever and might need treatment. So it's important to remember that pancreatitis does not rule out. You can have coexistent lesions. So the typical fluid collections are, as in the modified Atlanta, they could be acute peripancreatic fluid collections if it's early on, and these tend to be extra pancreatic. That's the important thing. It's outside the pancreas. There's no wall at this stage because they tend to be within the first 4 weeks. Beyond the 4 weeks, if they get a wall, it's usually the classical, typical pseudocyst that we talk about. Then we have these two follow interstitial acute pancreatitis. If it is following necrotizing pancreatitis, they can be acute necrotic collections, which can be both intra and extra pancreatic. If it's within 4 weeks of the attack of pancreatitis, or a longer duration, usually can result in walled-off pancreatic necrosis. These are technically outside our purview, and we'll be covering these in separate sessions. But just to put into perspective, that they can be associated with this. Sonia, would you mind shutting your mic off here? So cystic neoplasms, the commonest varieties are these four: the serous cyst adenomas, the mucinous cystic tumors, which could be benign or malignant. The star indicates the malignant potential. Can we mute the person? Okay. The intraductal papillary mucinous neoplasm. Technically, this is not really a cystic neoplasm if it is the commonest variety, the main duct variety, and that is outside our purview. But some of these which are branch duct can appear like cystic neoplasms. In an intraductal papillary mucinous neoplasm of the main duct type, the entire duct is dilated. So there is no actual cyst formation, but it can appear, I'll just show you some photographs where it can actually look like it is cystic. And the fourth variety, which is under-recognized, but is the most eminently treatable by, any of you, and that is the solid pseudopapillary, because there is no doubt in that whether it's malignant or not. It is a locally aggressive with very good prognosis. It doesn't metastasize much. So it's a fantastic one to, decide for surgery. There are other rarer variants, and the solid pseudopapillary seems to be the SPET or SPEN, seems to be actually commoner, as I'll just show you, than was earlier believed. There are other tumors like cystic neuroendocrine tumors, which can present as cystic tumors, lymphangiosarcomas, teratomas, leiomyosarcomas, and some true cysts like lymphoepithelial cysts and all that. So clinically, they can be asymptomatic and are picked up en passant while imaging for other diseases. So for a gynae disease, somebody finds the ultrasonologist finds a cyst and is investigated and found to have, possibly a cystic tumor. The features can be non-specific with just a discomfort or a feeling of mass in the upper abdomen. This is the most sort of confusing because we don't know. Suppose, for instance, there are gallstones or there's an ulcer side by side. So please make sure that when you get non-specific symptoms, please look for other common things. Also, clinical history becomes very important to rule out other causes, because this may not be the cause of symptoms. Merely because you see something doesn't make it ipso facto the cause of the symptoms. But sometimes the symptoms can be actually more directed. If it's compression, they can be gastric outlet obstruction or bile duct obstruction, or if it presses upon the vessels, we can get a sinistral portal hypertension, or if it's on the portal vein, we can get a extrahepatic portal venous obstruction kind of main portal vein portal hypertension. They can be sinister symptoms, which are again very important to get in your history, because these could suggest existing malignancy. So if you get anorexia, weight loss, progressive jaundice, steatorrhea, diabetes, which is new onset, it is important to think that this could be tumorous, or we might be missing another tumor which we are not able to see. So please, these are very important symptoms to correlate for a possible malignancy, either of the cyst itself or another one. Sometimes recurrent acute or chronic pancreatitis can can be manifested in IPMN. So, when looking at cases of pancreatitis, do keep an eye on the main duct, or whether there's features which could suggest that it is an IPMN. And quite frequently, we get the specimen pathology and we don't even realize it was a cystic tumor till it's already out. So you go ahead with something else, find some pancreatic tumor, or the very first cystic tumor I operated actually was a SPEN, which was diagnosed on CT scan as a gist of the stomach compressing the pancreas. When we opened up, the stomach was pristine, lifted off, and it was actually an exophytic SPEN. So SPEN is solid and pseudopapillary, so it can be a wide variety of cyst or solid elements. So when you're faced with a cystic lesion on a CT scan or an ultrasound, the questions you have to ask yourself: is this lesion a true cyst or a pseudocyst? Is the cyst neoplastic? Is it symptomatic? And if it's symptomatic, are the symptoms likely to be attributable to a cyst? Don't be trigger happy and just remove the cyst and we're still left with gallstones or peptic ulcer or something else. We need to know what is the natural history of the lesion, and that's why we need to know the type of the cyst, what their pathology actually reveals, and in case surgery is needed, how aggressive do we need to be? So just to summarize, get the important ones out of the way. The mucinous cystic neoplasms tend to be much commoner in females. The SPEN is also common in females, but slightly less so. So most of them are actually common except the IPMNs, which tend to be slightly commoner in the males. The distribution within the pancreas, the mucinous tend to be in the tail, which is good because all the mucinous tumors tend to be have a pre-malignant potential. So it's easier to sort of resect the tail rather than getting an innocuous lesion in the head of pancreas. We are more worried about trying to prove that it has more malignant potential, because the surgery should not be more lethal than the disease itself. That's a very important equipoise we have to maintain here. So the mucinous intraductal papillary neoplasms have a ductal connection, the others don't. So you could get an amylase increase, so that confounds the fact that some of them can have associated pancreatitis. But whenever you're doing a aspiration, in case you need to do it, always look for an amylase, and that tells you that there's a duct connection. The cyst contents will be mucinous in the mucinous tumors. So if there's a very high viscosity in the aspirated fluid, you're reasonably sure that this is one of the mucinous tumors. And the important thing is, please send these for cyst CEA, because if it's high, it could be existing malignancy or pre-malignant potential. But more importantly, all the mucinous tumors have pre-malignant potential. So if there's a doubt, we probably need to look at the mucinous content. And the serous ones, of course, have a clear serous fluid. The epithelium and the stroma. So the stroma, the important thing is the mucinous cystic neoplasms have an ovarian stroma as well. I'll just come to that in a minute. So just a brief one slide for each. The serous cyst adenomas are, they evolved from the centroacinar intercalated duct system. Most of them are in women in the older age group. So if you imagine old lady coming with, a large, honeycomb lesion in the head of pancreas, very likely to be serous. You can actually keep them on follow-up and see how it's growing. They're invariably indolent, and malignancy is extremely rare. There's only one series been reported, I think, from Mayo. All the others are only case reports of serous cyst adenocarcinoma, and they're also just a mere handful. So for all practical purposes, they are, probably not malignant. And even if reason for operating them should not be malignancy worry. All those ones which have been reported also gave enough time for the malignancy to manifest. And they were still operable at that stage. So a follow-up is probably worthwhile in all the serous cyst adenomas. So treatment is required only if they're enlarging with any sinister signs coming, or if they're symptomatic. And the CT features are very typical. They are microcystic, so multiple, like a soap bubble appearance, a honeycomb appearance, or a sunburst appearance, as if there's a sudden burst of sun. I think I have a slide on that. Stellate scar in the center also suggests a serous cystadenoma, as the central part gets gradually compressed and over time, fibrosed. Rarely it can be calcified, but these are, a very random, minimal calcification and has clear serous fluid. It's very rarely it can be macrocystic also. And it is a common feature in von Hippel-Lindau disease. The von Hippel-Lindau can have simple, the polycystic type of simple cyst also. Most commonly it has serous cystadenomas, which are non-malignant. So in VHL, when we are operating for malignancy, it is always for a malignant neuroendocrine tumor. So neuroendocrine tumors are also rarely associated with von Hippel-Lindau, in addition to serous cystadenomas, and these are the ones which can turn malignant. And sometimes they can appear like solid adenomas also if the solid elements fill up the cyst completely. So that's a typical thing. The soap bubble appearance on the ultrasound scan, and the CT actually shows you that typical thing sometimes with this kind of scarring where the central ones tend to get compressed. Here, I just include this to show you there can be some amount of compression and minor enlargement of the pancreatic duct as well. The second major variety, and probably the most important, is the mucinous cystic tumors, almost exclusively in ladies. The mean age is a little younger. So if you imagine the serous tumors as a grandmother, this is in the maternal age, older mothers. It's more common in the distal pancreas. It has a definite malignant potential. So this is the one we need to be worried about the most. It basically has mucinous tall columnar epithelium, and the pathognomonic feature even in males is the ovarian stroma. So most world authorities agree on this because this can be confused with the branch duct IPMNs, which tend to be much more innocuous. So if we see mucinous tumor with ovarian stroma, it is mucinous cystic. Some Japanese authorities believe that this is not mandatory, but most people think that this is a very important feature for this. They have a water density on imaging, a few loculi, so much less than the serous tumors. But importantly, the septae can enhance because these are vascular. Sometimes because of the dystrophic calcification, there can be a calcific rim. The wall tends to be much thicker than the serous cysts, and the solid parts may harbor a malignancy. So do look for solid parts, particularly those which are not gravitational. So in pseudocysts, we can see the debris settling down, and it will be along with the in the gravitational parts, lower parts. So if you are seeing anti-gravity solid parts, think of mucinous tumors and be suspicious about them. You can actually change position during ultrasound and see whether those solid parts are moving or not. So typically here, these septae which are enhancing, and typically incomplete. They can be complete also, but I put this just to show you that incomplete septae, here as well as in other, mucinous tumors in the biliary tree and all that, can have, is very suspicious for mucinous tumors, which are pre-malignant. The third variety, which is common in the East, in Japan, China, and Southeast Asia, it's getting more recognized in our part of the world as well, but probably is not as common as the huge volume of literature that we have. So I'm not covering it in greater detail. We'll probably have a separate session on this because this should be dealt with by a specialist. It is a mucin secreting papillary tumor arising from the main or branch duct, commoner in men around 65. So it is focal, multicentric. So it can be multicentric, and in earlier days, till about 2 decades back, the standard treatment was actually total pancreatectomy till we realized that it could be extensive also in the main duct. But now we know we could do a more localized dissection as well, but has a definite malignant potential if it is from the main duct. Important also is to understand that they have coexistent or secondary pancreatitis, particularly in the adjacent tissues. The malignancy is common in the main duct, as I said. The epithelium can be intestinal, pancreatobiliary, or gastric foveolar type. The stroma tends to be hypocellular, unlike the MCN, because it's basically a ductal tumor. So that's the typical feature. You get these finger-like projections all jutting into the duct. So very typical things. So the variety of lesions you can see is like this, where the main duct is dilated with some of these solid elements actually either filling it up like this, or actually even forming loose septae which can get displaced over time. So each time you do it, they might be slightly different in that. Sometimes they get hugely distended, and that's why they can actually mimic this. So you can hardly see any pancreatic parenchyma, and they can mimic almost like the entire pancreas being converted to a cyst. And this is the typical endoscopic feature where you see these fish mouth papilla, and this mucin is actually coming out. Normally, if you have a huge open thing, things should not be stuck there. Because of the viscosity, it tends to look like that, like a fish with an open mouth. And finally, the fourth one, which is probably more commoner in our part of the country, it is in younger females. So much better prognosis, but the definite malignant potential with a very good prognosis. They tend to be large, solitary, well demarcated, and that's why it's called solid pseudopapillary epithelial neoplasm. So it could be any variety from solid to cystic to all the grades in between. It has these perivascular discohesive polygonal cells, and it's a very typical pseudopapillary pattern with hemorrhage and necrosis. In the pathologist can diagnose it even without immunohistochemistry, but traditionally alpha-1 antitrypsin used to be done earlier as in the immunohistochemical markers. But currently one of the best is beta-catenin along with CD99, and the CD99 shows you this kind of perinuclear dot positivity, which is very typical for SPENs. The cyclin D1 can also be positive. The CT, the CAT scan typically shows peripheral hypervascularity and central cystic nature. So that's the typical feature. So, and since it's got such a good prognosis, tends to be locally malignant, we can do much more localized resections. We can just do median pancreatectomies and things like that. So a cystic tumor on cutting, if it looks solid, it's almost pathognomonic of, in a young lady, is almost pathognomonic of a SPEN. You sometimes don't even need most of these we have diagnosed on gross cutting across the section. So just to recapitulate, the mucinous ones are the most important, and there could be a gender bias in each of them. The ages, remember the cysts tend to be multilocular cysts within the cyst. In IPMNs, the cysts are next to the cyst by cyst. The IPMNs tend to be more in the head, so we need to be very sure they're malignant or pre-malignant. So we might need to take biopsies from the head, or cores from the EUS guidance. If they're in the tail, you can just do a distal pancreatectomy, and the IPMNs of course have a ductal communication. And the histology, ovarian stroma in the mucinous cystic tumors. So this is a pan-Indian study which was done from about 8 centers across the country, and reasonably large volume centers. And what they found was they collected about 423 patients. And now actually with increasing recognition, I'm sure if we do this now, they're going to be even larger volumes. So just to give you an idea about the distribution, 23, so this is the operative ones. So even despite knowing all these things, a quarter of them turned out to be serous cystic neoplasms, 30% were mucinous, and 28% were IPMNs, and 8% were IPMNs, and one of the largest groups was actually the solid pseudopapillary epithelial neoplasm. So it's very common and under-recognized. Beyond this also, I've found a lot of studies, a lot of case reports in all our conferences we get presented when they present SPENs as a rare diagnosis. It's not rare. Malignancy is important in the, were found in about almost a little less than 10%. And they could be both adenocarcinoma or malignant IPMNs or mucinous cyst adenocarcinomas. So these tend to be, wherever there's a doubt of malignancy, we must resect it. The females, of course, was more common, and only 81% were symptomatic. So almost 1/5 were still operated for asymptomatic. So if that's the same subset as the serous cystic ones, maybe we could have actually skipped out those. Laparoscopy is, of course, very useful if possible. So assessment aims are to identify the lesions with malignant potential, even in pancreatitis, and remember, up to 50% can be neoplastic. And follow up, if we are conserving, look at the size, the mural nodules, and if they're symptomatic. Imaging modalities are pretty much typical, so I'm not going to run through them. But the CT is very important for looking at the calcification, septae, nodules, and the presence of pancreatitis. MRI actually gives you a better cyst morphology and is excellent for following up IPMN. Also, it is irradiating, so useful. ERCP and pancreatoscopy is extremely useful for the IPMNs. You can also take brushings. You can do intraductal ultrasounds to see if they are invasive. So extremely useful, but needs advanced centers. So some of these might need advanced centers to actually look at it. PET may be a useful marker for proliferation, but not much studies have done using it. So where it's appropriate, it could be an ancillary test. But the best modality is probably endoscopic ultrasound. If there's any doubt that we need to operate on them, we should probably try and prove it. Or if you're conserving them and there's a doubt, particularly in the head, it's a fantastic tool, and sampling can be used for the cyst fluid analysis. And they can be tested for a variety of biomarkers, for cytology, for the presence of mucin, because it automatically shows a pre-malignant potential, and CEA. So just to stress this. So how do we determine what to do? So age and gender is important. So an elderly lady with typical serious features who's asymptomatic, we probably do not need to operate her. Then we make a basic assumption of what is the cyst type and follow up from there. So most of these are not very aggressive malignancies, even if they are. So we can have the luxury to follow up in doubtful cases, patients who have a borderline comorbidity, who would be high anesthesia risks. You might follow them up for 4 to 6 weeks and see if it's growing or not. So you can look at the biology, you can look for the sinister signs, and still they tend to be operative. So location is very important to know how aggressive you want to do surgery. If it's in the tail of pancreas, we tend to be have a lower threshold for doing surgery. For a Whipple, we need to be reasonably sure. So I think for when we are going to do a Whipple, we should try and get a tissue diagnosis as far as possible. So important that if there are no symptoms, pseudocyst or serous cyst, they might need just a follow-up. So important to look at the history, ultrasound, CT, all the age, gender, comorbidity, history of pancreatitis. All these features which are there, imaging features, are bland. Think of pseudocyst. If it's less than 2 cm, small size, no mural nodules, typical features of SCA, just follow-up imaging. Bigger ones you might need with symptoms, with septi, mural components, you might need to do an EOSFNA. So if there's an equivocality, you can do a second imaging modality. So when do we do surgery? Lesions in tail which are symptomatic in middle-aged women, or there's a higher chance of it being a mucinous tumor. Typical serous tumors which are more than 4 centimeters, which are growing or symptomatic. Mucinous tumors, both MCN and IPMN, main duct of any size. Branch duct IPM is slightly more strict criteria if they are larger in size or increasing in size on follow-up, where they're associated with main duct enlargement, dilatation. If there are mural nodules within the branch duct, especially if they are vascular, if they are symptomatic branch duct IPMNs, or if the cytology is suspicious, they all need surgery. CEA is routinely done. I just put that CA99 there because while CA99 is a very useful serum modality, if CA99 is high in the serum blood, it could be a marker of malignancy. But CA99 in the cyst fluid, please don't waste it. It's a waste of money. The highest CA99 we found in some of the benign serous tumors. So there is no evidence of CA99 use in the cyst fluid. But CEA, this figure of 192 was one of the first publications, but a variety of numbers have been given. There's just been an update last month from one of the centers showing a much better yield if it is lower, but it's a trade-off. Some people have even used 30, higher than 30 as a value, but it is basically a trade-off. The higher cutoff you use, the more is the specificity of that. But for a more sensitivity, you need to lower your cutoff. So use that sensibly with all the other imaging and historical features. So type of surgery, of course, follows wherever it is. For mucinous tumors, we tend to add some kind of lymph node resection, just especially if they have a doubt of malignancy. So you add a splenectomy, you add a lymph node dissection. If it's a low-grade central tumor, like typically the spens tend to be there in the middle pancreas, you can do a median or central resection, despite the fact that you can have two, either two ends cut off. You can actually ligate off the end towards the papilla and drain the distal end, which is much more innocuous if it leaks also. Total pancreatectomy might be required for von Hippel-Lindau if there are multiple cancerous neuroendocrine tumors, and for diffuse main duct IPMN, which is got throughout, the features are there in both head and tail. Laparoscopy is feasible, and for many of these has the potential to become standard of care. Just a small last slide on ablative therapy might be needed. In very minimally symptomatic elderly comorbid, there's a new technique that you can actually, under EUS guidance, ablate it using alcohol or paclitaxel. Only rider being that there's a potential to miss malignancy. So only do it for this cohort, which can be done even at your centers. So must be counseled that there's a small possibility of missing a malignancy, but operating on them might be more malignant for the patient. So complications can be there in terms of splenic vein thrombosis or pancreatitis itself, and we do not have long-term data, but it is accumulating. I think in your lifetime you're likely to see some bits of it. So just a algorithm. I think we've covered most of this, and we've okay for time. So if it's mucinous features, high CEA, columnar epithelium, we know it's with a low amylase, it's a mucinous cystic tumor. If there's no mucin on the FNA, it's low in CEA, cuboidal, it's serous, you can avoid surgery. If it's equivocal, you can do molecular markers, you can look for neuroendocrine and malignant cells. Those are very common tumors as well. Or you could repeat imaging and confirm that it's either MCN or IPMN. If there's high amylase and CEA, think of the branch duct and then think of surgery. So important to follow up. If you, this is one place where we do get the luxury, like neuroendocrine tumors. There's another place where we don't have to scare the patient into surgery right away unless there are existing sinister symptoms or definite markers of malignancy, or the age and other profile makes you feel that it might be too dangerous to wait. For bulk of them, 80-90% of them, you do have the chance of actually following them up and postpone your success rates. So future, I think this is one area which is going to have personalized treatment. A lot of mutational analysis, proteomics has come up in a big way in terms of mucin profiling, and other cytological and chemical markers are, every conference we see a variety of these, and some of these are definitely going to become standard of care. Another very useful technique is the confocal laser endomicroscopy, but that's outside and this, along with the EOS FNA, has the highest yield. So I thank you for a patient listening, and welcome any questions and comments from Professor Kapoor and others.
So Puneet, the mainstay of investigation is actually the cyst fluid aspiration, which should always be done under endoscopic ultrasound guidance. The problem is the availability and accessibility. So suppose, because many of our colleagues who would be watching this would be from the African continent, and I presume that many of them may not have easy access to EUS. So in the absence of EUS, based on CT and MRI alone, how can we, or to what extent we can diagnose that it is a cystic tumor? And then if we can't make out which type is it, how to go about it? That is the practical problem.
Very good question, sir. I think in a resource constrained setting, it's very important to look at the imaging rather than the EUS alone. So EUS, I highlighted more to show you that it can actually solve a lot of problems, But even now, in bulk of the tumors, it tends to be a problem-solving technique only. So we can make a reasonable diagnosis in ultrasound and CT combination alone, and sometimes assisted on MRI. So if we exclude the IPMN class, which is not really a cyst in the pancreas, I think simple history taking and will take out quite a large number of the inflammatory tumors. You could follow those up with a higher chance of it being inflammatory and do repeats. And if they're reducing in size, we know that they are the inflammatory pathway of the algorithm. If their size is large and they're increasing in size, if the location is distal and the symptoms are high, I think even in the absence of EOSFNA, we can go ahead and do absolutely true. So if there's typical symptoms, if there are any other sinister markers, straight away surgery, even if it requires Whipple. But just wanted to stress that if you have affordability, that they can go to an EUS in the equivocal ones, in the high risk patient, where the patient is high risk or the surgery is likely to be high risk. It is probably, those are the ones, and they would probably be only in the region of 10 to 20% where you might need. So the bulk, as Professor Kapoor has tried to hint, is that we can actually deal with them even in the resource constrained setting without hi-fi investigations. Absolutely agree, sir.
So if the ultrasound or the CT scan suggests that the pancreatic lesion may be a cystic lesion or a mixed cystic solid lesion, should we always get an MRI done?
So if it's typical for serous, I mean, a lot of those things we can see, and if it's typical for serous and multicystic and that soap bubble kind of thing, we can actually wait and repeat after some time. I think MRI is much more useful for follow-up of branch duct IPMNs. Is the best. It's the modality of choice for following them up. But if, like you said, there are solid things. So I mean, I'm just wondering whether the subtext, whether you're asking about SPENs. So SPENs, it's not been. CT has been excellent for SPENs, and where there's a high index of suspicion. So I've seen every center, there is the radiologist takes time to get this, and once they get SPENs, they almost always diagnose it correct on that. So I think the tissue diagnosis could be an issue if the patient is high risk, but if they're low risk, probably anything with solid elements should be, we should err on the side of surgery, especially if it's distal. If it's proximal, we could do MRI and possibly a tissue diagnosis.
Suppose the imaging confirms that it is a serous cystadenoma, there are no solid components. Does size decide the management?
So some people have put 4 centimeters as a cutoff. I think in our resource constraint setting, we should follow them up. I haven't found a single serous. We've studied we collected all those cases. Subsequently, also all those centers, I'm in touch with them, and including SGPGI and MG University and other centers, the other AIMSs and all that, and nobody's actually reported. So I mean, I think we should probably through the HPB and all that set and ISG set up registries for all these rare tumors. And I think like in the neuroendocrine thing, we can welcome other Asia Pacific and African countries also to join in that, because I think the collected data is much more important than the scare. So many of us scare our patients into saying it could be a malignancy. So the serious ones, my gut feeling is, unless the patient, you or the patient has a high index of suspicion for any reason, it should not be that size alone is probably not the criteria. I think the 4 centimeter thing in the Western guidelines has come more as a sort of protecting their own backs in the guidelines.
I mean, I also feel 4 is too small. I have some patients much larger than that under closed surveillance. The second question is about IPM, and maybe I missed this part in between because I had to sign some administrative papers. This differentiation between main duct and branch duct IPMN, because that makes a difference in terms of its malignant potential. So how do you differentiate, or how do we differentiate between these, and then the mixed, of course?
So the main duct IPMN, the entire duct is dilated, as I showed those some of those photographs, and I mean, technically doesn't come under cystic tumors because for the clinician it will come the typical cyst within the pancreas kind of a moiety will not come as a main duct IPM. It will be usually as a branch duct. So the difference is mostly morphological on the CT itself. So branch duct would tend to be distal, and typically it's not a imaging finding, it's more of a finding after removal or an autopsy, because it is you need to show the connection to the duct or a high amylase. So one of those things you need to show that it is from the duct, because I feel, when we were for a textbook, we had to put together a chapter, and when we looked at our own pathology patients, 2-3 of them actually I realized were didn't have the ovarian stroma, so they possibly were actually branch duct IPMNs. So when we say that IPMNs are rare in our country, we might be mislabeling them as MCNs actually. So that's why I was stressing the ovarian stroma bit. So what we found was that was extremely discriminatory, and since we didn't have amylase in some of those, we might be missing them. But all of them would have a connection with the duct. So the branch tends to be sort of peripheral, and the main duct. So the problem comes in uncinate lesion, which is a branch duct, may look like a sort of a deviating tumor or something. So since that carries a similar malignant potential, I think following that up, and if it's increasing or any of those mural nodules, vascularity, all those things coming in, is probably better to err on the side of a Whipple than not.
Although not really a cystic neoplasm of the pancreas, but in passing, you also mentioned that patients with chronic pancreatitis, in addition to dilated ducts, they may have intraparenchymal cysts. So should they be called cysts? Are they true cysts? Are they pseudocysts? What are they?
So actually, the retention cysts are true cysts because they are lined by those cuboidal epithelium. So pathologically they are cysts, but I'm not sure what is the clinical relevance. So I just mentioned it so that people are aware that because I found a lot of places confusing literature. So I just wanted to put that in perspective, that when they look at literature, they should understand what they are talking about. Most of those things are harbingers of chronic pancreatitis. So retention cysts can imply that it's a high grade. They might need, if it's associated with symptoms, they might need treatment for the chronic pancreatitis itself. Other places I found it mentioned, and that's a little more confusing, is that these should, when you have pancreatitis associated with retention, these will not actually resolve. So these should be treated upfront. So I'm not sure they need to be treated upfront, except if they are either symptomatic or they're likely to have a doubt of diagnosis. So by itself, I don't think they carry any significance.
That was the second part of the question. So when we are going in to operate upon for chronic pancreatitis, suppose there is an indication and we are operating, do we have to look for these cysts by an intraoperative ultrasound and make sure that they are also drained?
So no, I think that's a very important question, even for, when pseudocysts are there with chronic pancreatitis. So when we have chronic pancreatitis associated with pseudocysts, it's very important to realize that when we are operating them, the drainages of the duct. So, many of us include the cyst for drainage, but if we do not, there are enough studies to show if we do not drain the cysts, it doesn't matter. So we don't need to look for them aggressively. The main treatment is the decompression of the main ductal system and all the associated ones. So if we are looking for those smaller ones, we'll probably get the fray or the extended ductal drainage. We'll probably get these. If it's a bit of a trade-off, because most of them tend to be in the pancreas which are atrophic. So how much we need to chase them, I'm not really sure. But if there is evidence of a ductal drainage leak or something like that, probably the main duct should definitely be completely as big as possible. We should do a drainage procedure.
We also have Dr. Rajendra Desai. Rajendra, you want to add anything, say anything?
Not really, sir. I think it was very comprehensive.
So since we have a couple of minutes, suppose we have a tumor, cystic tumor, which we have not been able to delineate what it is. It's a mixed solid cystic, so it's not serous cyst adenoma. Does it make a difference whether it is in the head or tail? You did mention in between that threshold for surgery would be lower for tail. So would you say that if it is in the tail, we probably should go more for a excision?
Yeah, so it's lucky for the patient and the tumor, because more of the aggressive ones, the main duct, of course, it's the head which is involved. But if you look at, apart from the main duct IPMNs, all the others, the malignant ones tend to be in the tail. So I think epidemiologically, it would be important that we keep a lower threshold. So symptoms, distal and clear signs of malignancy, we should operate. So just for that reason, there's no clear objective reason to actually separate them. It's only because the risk of Whipple is much higher.
Any of the students want to ask anything? Raise your hand. Otherwise, I'll carry on with my questions. So next is about IPMN. The AIG group, Dr. Rebala Pradeep, he has been advocating that if you have everything on the earth, you have a pancreatoscope. So once you have done a resection, you put that scope in and see whether there are other lesions. So is
Absolutely. I think that's a very, very important point you raise, sir, because I think as we evolved from total pancreatectomy to regional pancreatectomy for the main duct IPMNs, one of the things we need to make sure is the rest of the gland we are going to leave back should be tumor free. So understanding that, I noticed that a lot of surgeons have misunderstood that it's all in contiguity. So they just say that if the frozen section margin is negative, we can close up the patient, but it's very important to realize that this is multicentric. It can even discretely in time. Just as I was leaving Amrita Cochin, we had a patient who'd had a tail IPMN 17 years earlier and now had come with a biliary IPMN after 70 years. So I think it's important to realize since there are general surgeons here, all papillary ductal tumors in the body tend to be, they can have discontiguous. So some of these cells can desquamate and implant somewhere else. So the papillomas of the renal pelvis can implant. That's why you do a nephroureterectomy, including a cuff of the bladder, because it can implant anywhere. Those papillomas, transitional cell tumors can implant anywhere. Likewise, the papillary gallbladder cancers can extend into the duct, the common bile duct. So since they have good prognosis, this is one of the few good prognosis tumors where we move the bile duct. So as a general rule, if you remember, duct epithelial associated papillary tumors tend to be multicentric. So here in the IPMNs also, I think it's very, very important pancreatoscopy because these ducts are dilated. So, nephroscopes or pancreatoscopes can be used, and make sure that as far as you can see that there is no discontiguous tumor as well, apart from just the frozen section.
There's a question that should intraop frozen be done for all cystic neoplasms or only
only for the IPMNs, because that is spreading along the ducts and you can miss. So where the gross findings you find, so for instance, if it's an uncinate tumor, which looks in the CT is only showing in the uncinate area. So now it's important to make sure that this is not crept along the ducts. The contiguous part, at least you'll be able to see. The discontiguous, of course, we need some form of scopy or graphy, but at least the contiguous things we should see, which we may not be able to palpate on mere, for the adenocarcinomas we are looking, because they tend to be infiltrating all along through the parenchyma as well. These are like something like the DPAMs, the pseudomyxoma. They will be along the epithelium, so we may miss it grossly. So it's important to get a margin. For all the others, it's the gross distribution of if you have access to an intraoperative ultrasound and you're sure, for instance, if you're doing laparoscopically, you're sure that you've taken the entire cyst, you do not need a frozen section.
Whenever operating upon a pseudocyst, should you always take a biopsy of the ball?
A very, very important point. I should have said that. Absolutely. So this is one thing I noticed when we switched to minimally invasive surgery. Many of the people stopped doing that. So I think it's very, very important. I've operated on several patients who've had a previous cystogastroscopy, and we've needed to do a total pancreatectomy in one along with a total gastrectomy. So it can be, so before we do any of these procedures, I think it was a dictum in the pre minimally invasive era to always take a biopsy. So my suggestion is that at least take a frozen section to establish that there is no epithelium on the, so if there's no epithelium on that side, you're sure that it's not a cystic tumor. You don't need typing or anything. If there's any doubt, if it's definitely high amylase, typical pancreatitis, you can probably omit a frozen section, but please take, that the typically what is described in Naihas mastery surgery is the 4 by 2 centimeter wedge. which ensures adequate drainage of the duct. So please send that particular disc for at least a permanent section, if not for a frozen.
There's another question. Do main duct IPMNs also present as discontiguous cysts? I think you said that.
Yeah, it's the main ducts only which present. Those which are only discontiguous is a branch duct. Some branch ducts can be associated with the main duct as well, and they carry the malignant potential of the main duct disease. So look at the main duct wherever it is there. The branch duct alone has its own potential, which is much lower.
So students, I think Dr. Puneet has covered the topic in great detail, and a lot of clinical tips he has given as to how to suspect, diagnose and manage these cystic neoplasms. But still, if you want to read more, please send me a mail, vkkapoor.india@gmail.com. Write CPN or CNP in the subject of the mail. So I'll send you the chapter on other pancreatic neoplasms, which cover both cystic neoplasms and neuroendocrine tumors from my book on pancreatoduodenectomy. So with that, thank you, Puneet. Thank you very, very much. And we would love to have you again on the Jaipur Surgical School according to your convenience. Any topic which you think is of interest. This audience is mainly general surgical, although I see some GI surgery students also, but we try to keep it more broad. So please let Piyush know. Piyush Varshney manages the faculty of Jaipur Surgical School. And thank you, Himanshi from Dwarika Hospital. That is the Dr. Avinash Tang's team. They have been providing technical support. So they record and upload all the videos immediately on the Gastrouniversity channel. And as I said, we have had, I was just checking, last Friday, Dr. T.D. Yadav did the second part of bile duct injury management, and within a few days, it has had more than 120 views already. The previous week, Monica Gupta, she did highlighted, that also has 80 plus views, and there are some lectures which have had more views also. So I think students are watching, and I hope they are benefiting from our efforts.
Yes, I think we could make a sort of an index of the thing and send it to the colleges, medical colleges as well, because I think whenever the kids have to study, the current lot of students I find are very visual, so they rely much more on videos. So I think it would be a huge help to them.
Okay, Himanshi, I think that's a good suggestion. We will discuss this, that please let us compile a list. You have the playlists on the Gastrouniversity channel, but we need to make it like a list. And
yeah, it's difficult to look. It's difficult to find that. Sir. Yeah. I
have the database of more than 1,000 students now, so maybe I can send to them. So I'll coordinate with the Dwarika Hospital team. Thank you. Thank you, everyone. Thank you, Rajen, for joining once again. Thank you very much. Thanks, Dr. Puneet.